Chapter 29. In Chapter 29 we will cover some kind of catch-all here. It's kind of some miscellany of some things that include non-traumatic musculoskeletal disorders and disorders of the soft tissue. So most of these really do not have an immediate life threat to them. However, a lot of them affect our patients that we deal with on a very regular basis. So it's important to take a look at these because they can have some overall impact on the patients that we deal with on a regular basis. As with all of our chapters, simply watching and listening to the lecture is no replacement for studying the chapters. You need to read and take notes and study that as soon as possible. Again, AEMT is applying fundamental knowledge to provide basic and selected advanced emergency care and transportation based on the assessment findings for the acutely ill patient. I have just a few objectives to this chapter that are found on page 691 and 692. All right, so an introduction. Muscle aches, weaknesses, rash, skin color changes, other musculoskeletal and soft tissue complaints can be signs or symptoms of other health problems. Sometimes we don't think much of them, but in reality, some of them can have some pretty serious causes that are underlying. We just don't often see them that way because they seem so minor and so benign. Most of the non-traumatic musculoskeletal and soft tissue disorders do not pose immediate life-threatening problems. However, they can compound them. All right, so the skin is our protective outer covering for our body, and we know that it does a number of things for us. It helps to protect us from the outside environment. It also protects the inside environment by maintaining a delicate balance. So it helps regulate our temperature. It keeps our water in, keeps infection out, helps us store and synthesize various nutrients, and provides sensory input such as pain, heat, cold, and whatnot, and slightly does a little excretion of certain wastes and body substances, and is really responsible a lot for allowing us to cool easily through the process of sweating. So the layers of the skin, we have the epidermis, the dermis, and then the subcutaneous layer. The subcutaneous layer is really kind of the transitional area that goes from the skin into the inner body where the muscles are. The epidermis, remember, is a bloodless layer, just a upper layer of protective cells. Basically, these cells have been, all the innards have been essentially replaced with some collagen to kind of give us a shell. It also makes it kind of a waterproof layer. Down in the very deepest layers of the epidermis is where we actually will have some of the melanocytes, which gives our skin its color, and then the living layers of the epidermis. On top of the collagen, we also have keratin, which provides another layer of protection. So it's a kind of a waxy substance there. So now, as our skin gets exposed to UV light, then we synthesize vitamin D3, and D3 is a precursor to our human hormone of calcitriol, and calcitriol that is vital for our absorption of calcium and phosphorus. So too little UV exposure leads to a vitamin D deficiency. That can too much UV exposure leads to skin damage. So if we have too little vitamin D, we're not creating the appropriate hormones to store calcium and phosphorus. That can lead to weaker bones. Melanin is the melanin production increases as the sun exposure increases, so it helps to cast a dark shell, almost like sunglasses, or a layer of protection over our skin by darkening to help reduce the exposure and the damage to things that are further in. We know that cyanosis occurs occasionally in patients that are hypoxic, as an example of how patients have the increase of deoxygenation in their body leads to the much darker colors that will manifest in kind of a blue tint to the skin. Remember, the yellowish cast or the yellowish hue is an example of liver failure, or what happens in liver failure when you have an excess of bilirubin. Remember, it's referred to as being jaundice, and you will have jaundice in the white of your eyes as well. The muscular system, we have over 600 skeletal muscles in our body, and they give us the ability to move, maintain our posture and our position, supports our soft tissue, regulates our temperature through heat production. Remember, the more we're working, the more heat we're producing. And then provide us with certain shape and protection, not to mention, it works in conjunction with our skeletal system to protect the most vital of the organs. So, for example, in the chest and in the abdomen. Skeletal muscle movement is controlled at the neuromuscular junction, or what we refer to as the synapse, remember, by the neurotransmitter acetylcholine. And that acetylcholine is the substance that's found there to allow the conduction of a signal across that synapse, to allow it to jump over and start to work on the muscle. And our muscle cells have something called myoglobin in them, and it binds to iron, which binds to oxygen, and they're found only within the muscle cells. So when muscles are starting to be damaged, they can release some of this myoglobin. So they will look for, in certain instances where you've had maybe a major insult to the muscle, you will look for some examples of this by looking for the myoglobin when that muscle has been injured. So it's a good example. Myoglobin can have a big problem when it gets down to the kidney tubules because it can help clog those up. Additionally, there's potassium that gets released when these cells are injured, and it can show up as something called creatine phosphokinase. Creatine phosphokinase, not creatinine. Creatine phosphokinase, CK or CPK, and there also is various variations of that are released by certain types of cells, such as the heart. So there's something that they may check in some cardiac victims or cardiac patients. They'll check the CKMB, which is the creatine phosphokinase myocardial band, and that helps to say there is muscle damage in the heart. We also have the skeletal system: bones, cartilage, ligaments, tendons. Remember, they allow us to move when working in conjunction with the muscles. Support, protection, calcium and phosphorus storage, and remember, that's where blood is created, is within the bone marrow cavities. We have other secondary or accessory structures, such as bursa, and the bursa or bursae, depending on if you're talking multiples or singles, are the little fluid-filled sacs, the joint capsules as they get referred to, and they kind of create a little shock absorber because they have a little fluid-filled center. And so places like the knee have what we refer to as the meniscus, and that's a cartilaginous pad that fits underneath basically underneath the above the synovial cavity or the bursa. All right, so the following joints, we know that's where bones articulate with one another, or quote-unquote move with one another. Some of them are immovable. Ligaments tie like things together. So ligaments will tie bones to bones. Tendons will tie muscles to bones. And the bursae we talked about. Okay, and as we change, the number of our skin cells change. They decrease. The number of skin macrophages, vitamin D production, oil production, the size of the elastin fibers and collagen production, circulation decreases, perspiration decreases. So all of these things take a toll on our skin, hence the reason why we start to see things like, you know, age spots show up because we don't maybe have macrophages to kind of break down some of these oddballs. Vitamin D production decreases, causing us to have an increased risk for bone problems and fractures. We see the elastin fibers and the collagen production slow down. That gives us more deep furrowed wrinkles, not the nice tight taut skin that we had in our youth. Because so many things are changing, we also will see things like decubitus ulcers start to arise. We're going to talk about that here shortly. But decubitus ulcers, we just don't have, the skin is not as fresh, it's not as easily repaired as it has been in the past. We have a lot of non-specific complaints again that go with some of these disorders. So the pain, weakness, swelling, redness, rash. A lot of non-specifics. It requires us to be a little bit more in-depth when we're doing diagnostics. So a list of that patient's medications can be very useful as long as you've got your medication reference, your medication guide. You can start looking those things up and say, okay, what is this used for? Patients may or may not really truly know what they're for. Checking them for decubitus ulcers. Decubitus ulcers occur in places in which are usually under pressure a lot. So the most common place to see decubitus ulcers is back on the sacrum and coccyx of the lower back. Also, you can sometimes see decubitus ulcers on the heels or any other place in which is frequently being compressed, essentially, against a surface. All right, so a non-traumatic musculoskeletal patient may be non-critical, but the complaint is localized or due to a problem with another body system. And then thorough assessment is necessary to make this determination. Is this truly a local thing, or is this a widespread thing? So we could say something like, you know, when we're talking about a soft tissue thing, oh, they have a complaint of a rash. Well, is the rash due to them coming into contact with something specifically, or is the rash due to a severe allergic reaction? Or is the rash due to them having a sepsis throughout their entire body? So they may be infectious or non-infectious. We've talked about a number of infectious diseases in the previous chapter. So things can show up as different types of rashes or skin disruptions, whether or not we're talking things like an anaphylaxis where we have urticaria. Maybe we're talking something that's like purpura for a patient that may have something like a meningitis. Gangrene is the result of an untreated infection. And it's basically when skin starts breaking down, releasing toxins into the body. It's got foul-smelling liquids, decreased peripheral circulation, and neuropathy can also lead to this. So when patients don't have such great circulation, it can allow things to kind of stagnate there. It may get as ugly as necrotizing fasciitis. This is also called the skin-eating strep. So it's a rapidly spreading infection caused by group A hemolytic streptococci. Basically, it's a skin infection that starts to quickly spread and devour other parts of the body. So it does not, they can almost watch it move, and it just destroys tissue. Often requires them to go in and cut off significant extra parts of skin and flesh to keep it from spreading. So they have to kind of cut into the good stuff in order to hopefully stave off the bad. Here's an example of a cellulitis. You'll see cellulitis on a fairly regular basis with our patients. We're going to talk about that here in a second. And then here's an example of a decubitus ulcer, which may look very similar to a necrotizing fasciitis. However, it's going to move along very, very quickly if it's a necrotizing fasciitis. So this would be something you would see on somebody's heel or the little small of, or the back of somebody's butt or their tailbone. Cellulitis is an infection of the skin and the subcutaneous layers. It causes redness, swelling, warmth, and pain. In many cases, people who develop cellulitis probably have a decreased circulation. They might have some neuropathies where they don't tend to feel pain as much. It can crop up. It probably crops up most commonly in, say, diabetics or people that are very, very overweight. It's not typically a earth-shattering event, but these people can slowly get sick. So sometimes they've had some sort of an injury there prior, and it doesn't fully resolve and then turns into a cellulitis. And they may or may not develop an abscess as a result of this. Decubitus ulcers are often called bed or pressure sores. The individual remains immobile for a long period of time. This is why sometimes when you go into nursing homes or you go into hospitals, you'll see that patients have turning schedules where a patient needs to be turned so they're not laying flat on their back for the entire day. So they'll generally lay in one position for about 2 hours, and then they'll try to go in and move them to allow the circulation to improve in that vicinity. I mean, you could think about it this way: if you pinch your own nail bed like you're going to do capillary refill on yourself, you see you blanch out all of that blood, and you make it all white. Well, imagine not letting go of that for hours and hours and hours on end, and their body was not strong enough to compensate and deal with that. So that's how a decubitus can develop. We also have chronic non-healing wounds. That's not necessarily decubitus, not necessarily a cellulitis, but it's maybe they nicked themselves or they cut themselves in one way, shape, or form, and it just does not proceed to heal. Very common in the diabetic patient. Diabetics frequently go in and get their feet checked to make sure they're not developing sores and ulcers that have been undetected. They get to the point which requires amputation. Immunocompromised patients, patients on steroids take longer to heal, and patients who are hypoxic, malnourished, or have poor peripheral circulation commonly will have chronic non-healing wounds. Their whole homeostasis is off. So when the homeostasis is not in good order, that's when these sort of things pop up. There's some other pretty rare skin conditions that occur from time to time. Things like toxic epidermal necrolysis, Stevens-Johnson syndrome, erythema multiforme. These are toxins that lead to detachment of the epidermis and the mucous membranes. So they generally cause fairly significant blisters to form, and then can become, basically large sheets of epidermis that just are sloughing off. So think about if you've ever seen somebody who's had a very severe burn and how skin just sloughs right off. It can look very similar to that. So both toxic epidermal necrolysis and Stevens-Johnson syndrome, they cause this massive sloughing. Stevens-Johnson is limited with 10% or less of the body surface area being detached, and in TENS it's generally 30% or more can be detached, cause these severe blisters. Both of these can potentially be caused by a specific drug therapy. So they'll watch some of these patients very closely for certain medications that they're treating. In most cases, there's a pretty good idea that certain medications may lead to this, but sometimes it's all based off of does the risk outweigh the benefit. So some things like NSAIDs, anticonvulsants, certain types of antibiotics, and gout drugs can be used to, or can be commonly seen to cause some of these conditions. If you run into one of these, it's basically treat them like a burn. You keep them clean, keep them dry, sterile dressings over any wounds. You can consider giving them some IV fluids, although you got to be very careful. That you got to make sure you find a limb that's not affected by this. The erythema multiforme, it also looks very similar to the TEN and the SJS. It has a minor and a major. Minor is basically red lesions that primarily affect the trunk, and major includes at least one mucous membrane in addition to the skin, but still affects less than 10% of the total body surface area. The primary risk factor to that is recent infection with herpes, but it also can be caused by certain types of drugs. So pressure caused by transport on a long backboard, even by a thin stretcher or even by a thin stretcher mattress, can lead to sore formation in just 2 hours. So if prolonged transports are common, do not place the patient on a backboard unless it is absolutely indicated for spinal immobilization. It does happen. There are times in which patients go into ERs and they lay on that backboard for 3, 4, 5 hours before they even can get an x-ray to make sure that there's nothing broken and they can get them off the backboard. Here's an example of osteoarthritis in the hands, where you've got kind of enlarged nodules at the knuckles there. In cases of patients with rheumatoid arthritis, it causes a lot more deformity. So osteoarthritis, or degenerative joint disease, is when we start to break down that cartilage in the muscles, I'm sorry, in the joints, and that causes inflammation there. Basically, things are getting worn out. They can have pain, warmth, tenderness, stiffness, swelling, sometimes malalignment and deformity of the joint. The hands and the spine, the weight-bearing joints such as the knees and the hip, are the most common places that we see this. It is very, very, very common. Obviously, the older you get, the greater chances that you have some forms of arthritis forming. People who have had, say, infections, injuries, joint replacements, whatnot, tend to experience arthritis a little bit sooner than others, or a little bit more commonly. There's another joint disorder called ankylosing spondylitis or spondylosis, where the bones that form the joint start to become fused. So that's going to change the posture and really limit their mobility. So it's almost like they are starting to lock up or rust at their joints. Gout is a form of arthritis. It's caused by uric acid being deposited in the joints, typically in the foot, but sometimes it's also in the upper extremities. So basically they have excessive amounts of uric acid that's not being disposed of quite correctly by the urinary system or the renal system. And so it causes hot, painful, swollen joints. Usually causes pretty severe swelling to some of those areas. You can see that picture on 29.5 shows an example of gout. Or on page 697, it's figure 29.5. Bursitis is the inflammation of the synovial fluid filled sacs that protect the joint. So basically the little shock absorber in the middle of the joint has become inflamed. And this can be shoulders, elbows, ankles, knees, hips. So a lot of your repetitive motion injuries, say for a lot of sports like tennis elbow and whatnot, are actually a type of a bursitis. All right. Obviously, over time, we have a lot of wear and tear on our joints. The heavier you are, the more wear and tear you have on it. Sometimes we work it way harder. If you've had repetitive injuries to it, say you have several knee injuries during college football, high school football, you're going to run the risk of having more and more damage. In osteoarthritis or degenerative joint disease, that cartilage starts to break down. So we can look at some bone disorders. With bone disorders, we have a lot of non-traumatic things that occur, such as osteoporosis. We're going to have an example of that here, where we look at spongy bone here, where we have much more a lot more open cells and spaces in our osteoporotic bone. We can have osteopenia, which we have just a decrease in bone mass that occurs with aging, and that's fairly common. But osteoporosis has then a pathologic consequence where it goes over the top a little bit. So our bone mass is supported by a number of our vitamins, but remember, over time, we start to decrease the amount of the various vitamins we have in our system. And some of those vitamins can lead to a couple of other diseases such as scurvy or rickets. But physical stress on the bones will increase our bone strength because of osteogenesis. So as we start to take more and more pressure off as we age and we start to have a lot less activity in life, it then reduces the stress on those bones and it makes them actually become a little bit weaker. Kyphosis. There's an example of that on 698. It gives you an abnormal curvature of the spine or the hunchback appearance. It's probably commonly confused with scoliosis, which is more specifically a curvature side to side in the spine. We can have a variety of bone cancers such as osteosarcoma, Ewing sarcoma, which are seen in children and young adults. We can have some other things such as Paget's disease. Paget's disease actually causes some very mutated bone growth. It gives people very, very, very strange looking, oddly formed bones. Remember that lymphomas and multiple myelomas are lymphatic cancers, but can affect the bones. A lot of times some of those cells are created within the bones themselves. They can certainly affect the bones. Cancers from other sites can metastasize, and metastasis basically means they kind of migrate. They can migrate into the bone, cause some bone cancers there, causes weakness and pain, and something called pathologic fractures. Pathologic fractures is when it fractures without trauma. So sometimes they're just laying there and a bone can break. So we move into muscle disorders, things like muscular dystrophies. These are genetic diseases, and it causes progressive muscle degeneration or weakness. One of the most common ones is Duchenne's muscular dystrophy. It typically affects males between 3 and 7 years of age. So as these muscles degenerate and they break down, they cause rhabdomyolysis. And rhabdomyolysis is a free bits of muscle, myoglobin, that is discharged into the bloodstream, goes down to the kidneys and starts to clog the kidneys up. So the kidneys can't work at their capacity. Also can be caused by sepsis, can be caused by seizures, severe trauma, crush disease. Talked about that. Hyperkalemia can occur because as we're breaking stuff down, we're also discharging potassium into the system. That can cause cardiac dysrhythmias. We have things such as a fibromyalgia. Fibromyalgia is a chronic inflammatory disease of the musculoskeletal system. It's still a lot of non-specifics to it. It's not something that's easy to diagnose. So they generally have multiple tender points, so 11 out of 18 identified points have to be tender from time to time. Poor sleep, muscle stiffness, muscle pain that has really no other explanation. A lot of the treatments for it still are kind of in a experimental phase. I tried some things that affect GABA to kind of help control some of the symptoms here. Commonly associated with chronic fatigue syndrome. Neck and back disorders. There's several disorders discussed throughout the chapter that lead to back pain, whether it's muscle issues or maybe it's bone issues. Maybe it's something like kyphosis. But non-traumatic back pain is very, very common with a lot of people in the United States who have chronic back pain. Sometimes it's from inactivity. Sometimes we get it ourselves from overuse, from straining. May blow a disc. So they show an example here where this disc has herniated. So basically it's blown out. And by doing so, it's putting excess pressure on the nerve. And when it puts that pressure on the nerve, then it causes an increase in pain and potentially loss of function. There can also be things in which the sciatic nerve, which runs down along the leg, can be pressure can be placed on it. You get sciatica. It usually causes pretty severe pain and or tingling in a leg, and low back. Non-traumatic back pain can be worsened by spinal immobilization. So think about that twice. Just because they're complaining of back pain, maybe if we do a little bit further evaluation, we can determine whether or not does this person truly have a traumatic injury, or is this something that's been going on that is probably non-traumatic and something that just making them comfortable and getting them transported in for evaluation is actually the best plan. An example of scoliosis, I think most of us remember from elementary school getting checked for scoliosis. That's an abnormal lateral curvature of the spine. Throws the back out of alignment. Can be a little bit more difficult to detect. In very severe cases, those people end up with either surgery, with putting some rods in their back to keep it straight, some braces to kind of keep them in alignment to try to get them to grow straight. All right, so a very short chapter. It's a non-traumatic musculoskeletal soft tissue complaints have a lot of underlying causes. Consider systemic causes and localized problems. Obtain a patient's list of medications, kind of give you some key ideas, and then understand the mechanisms and consequences of the various and specific disorders.